Hello, everyone, and welcome back to our multiple sclerosis continuing medical education series. My name is Lucas Kipp, and I'm a clinical assistant professor and MS specialist here at the Stanford MS Clinic in Palo Alto. In our first lecture, we discussed the immunopathogenesis, epidemiology, and risk factors in MS. And today we're going to be exploring the clinical presentation and diagnosis of MS, starting with some clinical cases. And what I'm hoping you'll get out of today's lecture is applying a four-step approach to confirming an MS diagnosis, and really being aware of the red flags and as well as the consequences involved in MS misdiagnosis. To start today's lecture, let's work through a clinical case to try to illustrate some of those key elements we consider for making an MS diagnosis. So this is a 27-year-old woman who presents to your office complaining of a 4-day history of loss of sensation and tingling that initially started in her feet, a little bit more on the right than the left. And over the course of 4 days, these symptoms slowly came up into her torso to about the level of the clavicle and then spread into both of her arms. The only other symptoms she noticed at the time were if she bends her neck forward, she feels that those paresthesias are increased, and she's been feeling really fatigued, over this week that these symptoms have been occurring. She's an otherwise healthy 27-year-old. And when you go to examine her, you find that she's got reduced pinprick sensation from about the level of the neck down. So you're using a little pin and you're poking down her back, and you notice that on her neck, she says, it just doesn't feel as sharp below that. You get your tuning fork out and you're putting it on her great toe, and she only feels it for 3 or 4 seconds. And someone her age should really feel it for at least 10, 15 seconds or so. So her vibration sense is reduced in her feet. When you tap her reflexes, you notice they're jumping off the table. And when you tickle the bottom of her foot, do that Babinski reflex, you see that her toe is curling up. So the first question that I want you to ask yourself is, where do you think the problem in the nervous system is that is causing these symptoms? This is really the first step in determining what the problem is. It's actually determining where the problem is. So localization is really the hallmark in neurology. And the first question that you try to ask yourself is, do we think this is a peripheral nervous system problem, or is this a central nervous system problem? And so from her description of symptoms, how can you get both feet involved at the same time? Well, it could be that the small little nerves in the feet were affected, and that slowly spread up the torso and into the arms. Or could it happen in the spinal cord? Now, there's some key things from our exam that point us towards the latter. So if you can find hard findings on your exam that point towards a central nervous system or an upper motor neuron process, that helps you tease out whether these symptoms that could theoretically be peripheral or central, it really helps you figure this out, that this is a central nervous system problem and must be coming from the spinal cord. And those key things are brisk reflexes, upgoing toes, also that sensory level on her torso. And so we would think that this is something happening in the spinal cord and probably in the neck, the cervical spine, based on the fact where that sensation changes. Does anyone know what it's called when you bend your neck forward and neurologic symptoms get worse? So this is something called Lhermitte's phenomenon, which also localizes to a problem in the cervical spine. So just from her history alone and her exam, we know that something is going on in her cervical spine. The next question is, well, what do we think it is? And that's where the time course of symptoms is very important in neurology. So things that happen in seconds to minutes are usually something like vascular, like a blocked pipe, like a stroke, versus things that slowly happen over many months usually imply either a degenerative process or something that is slowly growing or compressing, something like a tumor. For things that come on over days to weeks, those are usually inflammatory in nature, whether that's infection or autoimmune disease, etc. So the time course of these symptoms is really pointing towards an inflammatory etiology. And so just from this case alone, we think it's inflammation, we think it's spinal cord, which is called myelopathy. But if we think it's due to inflammation, we call it myelitis. So this is the clinical presentation of transverse myelitis. So transverse myelitis is really just a catch-all for any type of inflammation in the spinal cord. It doesn't tell you what the etiology or the reason for that inflammation is, but it's a very common presenting symptom of multiple sclerosis. And this is what it looks like. So this is a sagittal T2 scan of a spinal cord. This is C2, C3, C4, C5. So we're really very close in terms of our localization on our exam. You can see that within the cord itself, there's a hyperintensity, a white spot. And if we look at it on an axial view, we see it here at the edge of the cord. Is this transverse myelitis due to multiple sclerosis? Well, as we're going to point out, to make an MS diagnosis, you've actually got to prove that you have had 2 episodes of inflammation that are separated at 2 different points in time and at 2 different locations within the nervous system. So if this is all we had, we couldn't make an MS diagnosis yet. We could just tell this woman that you have had an episode of transverse myelitis. It may be the first presentation of MS, but we can't quite get you to that diagnosis yet. So over the course of the next few months, she significantly recovers. Her loss of sensation slowly recedes, and she goes back to what she thinks is normal. Now, a year later, she comes back, and what's happened is she's woken up, and she feels like there's some pain as she moves her right eye. And over the course of the day, she notes that it's almost like that right eye is like looking through a window with some water on it. It's getting blurrier and blurrier as the day goes on. And by the next morning, she noticed that that eye is gray, and she can just see shadows and outlines of it. And that's where she gets worried and seeks medical attention. By the time she sees you in the office later on that second afternoon, she can only see the big E. So her visual acuity has significantly deteriorated. Her exam also shows in that right eye, she can't see colors as well. So you may have seen some of our reflex hammers that have a little red tip on them. That's so we can test for color desaturation. When you do the swinging flashlight test, you also notice that she has a difference in her pupils, what's called a relative afferent pupillary defect. The way that we test that is that we shine light into the non-affected eye, and then we quickly swing that flashlight over to the affected eye. Now, in normal eyes, no matter what eye you've got the light in, both eyes should be maximally constricted. And so what happens though, in someone that has an RAPD, if you swing the flashlight into the affected eye, it actually dilates because not enough light is getting back to the brain to keep the pupils dilated. And so if you go back to what we talked about in terms of where this might localize, what do you think? Decreased visual acuity, relative afferent pupillary defect, decreased red color. Those all point to an optic nerve problem. So light isn't getting back down the optic nerve well enough. And if we think about the time course that the symptoms came on over days, We don't think someone's had a stroke to their optic nerve, which would have happened like that. It's not something that's been going on for months where we think they've got an optic nerve glioma that's growing within their optic nerve and slowly taking their vision away. This is probably an inflammatory condition that's affecting that optic nerve. And this is what's called opticneuritis. And just like transverse myelitis, it can be a common clinical syndrome that we see in multiple sclerosis, where symptoms come on over days to weeks, plateau, and then improve over weeks to months. And acutely, what this looks like on MRI, these are where the eyes would be. These are the muscles that move the eyes. And right in the center is the optic nerve. And you can see that optic nerve is brighter than this side. So this is an enhancing optic nerve, which means it's actively inflamed when we took that picture. The long-term sequelae of optic neuritis is most people don't get fully back to a visual acuity of 20/20, but some do. And often we see some long-term findings, which is disc pallor. And that's what it looks like here. If you take your fundoscope and you look at the back of their eye, after a few months, you may notice that part of that disc looks a little bit more pale compared to the healthy pink part of the disc. Acutely, you won't see anything in the back of the eye because the inflammation is happening behind the eye and the optic nerve, but you lose some of those axons from the injury, and that can show up as a little bit of pallor at the head of the optic nerve, which you can see with your fundoscope. So now that this woman has had 2 episodes of inflammation that's occurred in the central nervous system that sound like 2 typical demyelinating events, she would meet our diagnostic criteria for multiple sclerosis. Now, the challenge with multiple sclerosis diagnosis is that it can cause a wide variety of symptoms. So if you're a young 20 or 30 something and you've got a tingly finger or you're a little bit off balance or you get dizzy one day and you Google symptoms, MS is always going to come up. And that's a really scary thing. And if you don't see MS in your practice every single day, it can really be daunting trying to figure out, should I be worried about MS or not? So what I'm going to try to explain here is some of the ways that you can try to figure out whether or not the symptoms that someone's coming into your office for could be related to demyelination, which is that pathologic process that causes the symptoms and ultimately leads to an MS diagnosis. One of the things we already talked about in the past lecture is even just using some of that epidemiological data to know what people might be at risk. So we've already talked about patients between the ages of 20 or 40, that millennial generation are the ones that you guys are going to be seeing in the next 10 years that are the ones whose neurologic symptoms you really want to be attentive to. But no matter where or what the symptoms are, the key part is that those symptoms follow a typical timeline that we'd expect for demyelination. And that really looks like this. So the time course is subacute. Symptoms generally evolve and kind of slowly get worse over hours to days, sometimes days to weeks. Then there's usually a plateau. And then over the course of the next few weeks for months, we expect people to get better. And so often, if patients are coming in the first time, we're only seeing them here. But often people, if we actually take a history and say, has anything like this ever happened to you in the past? You may find they had, a numb hand that occurred for a couple of weeks, but it went away on its own and they never sought medical attention. And that's often really common in people, particularly young people who have more capacity to recover and repair, who think, I probably just pinched a nerve and it got better, or they get misdiagnosed as carpal tunnel syndrome that improves. And so not only do you want to take the history of the symptoms that you're coming into the office for, but ask if anything has happened in the past that may have followed this time course. Because this is the time course we'd expect of demyelination that slowly occurs to a point where you're not getting the signals being able to run up and down the axons to cause symptoms. But then we expect improvement over weeks to months after those immune cells get out of the way and you actually get some recovery and some healing. The next key part is, if they tell you that they have these symptoms, can you find objective evidence on their exam or on an MRI that proves that what they're telling you actually happened and caused some fundamental damage in their central nervous system? And so these are kind of the steps that I'd encourage you to use if someone comes in to your clinic that has some neurologic symptoms. Ask yourself, is this a classic kind of clinical presentation or a clinical syndrome that we know is related to multiple sclerosis? So something like optic neuritis, transverse myelitis, that follows that typical time course. Then you want to examine the patient and say, okay, I think that these symptoms are coming from the spinal cord. Do I find any evidence on their exam that there's still something there that fits with the symptoms that they tell me? Then you go to the MRI and you say, can I find the lesion? Can I find the scar that caused that spot? Because those scars never fully go away. They always relieve some kind of residual thing where you should be able to find the spot that caused their symptoms. And if all those things are true and there isn't a better explanation, so working through a differential diagnosis, and we'll talk about some of the blood tests and whatnot that can be done to make sure this isn't something else. If not, this is MS. Now, we do have diagnostic criteria for MS. And if you stick to this, this in most cases shouldn't lead you astray. And if you've got any questions, that's when you really want to get people to an MS specialty clinic who've got a lot of experience here. But the key thing I want you to remember is that not all MS symptoms are related, not all neurologic symptoms are related to MS. So what you want to try to figure out are the time course of symptoms typical of what we'd expect or reflect a demyelinating event? And this is something that comes on acutely or subacutely. It's got to last, by definition, at least 24 hours, but usually it lasts days to weeks. And it's got to be in the absence of fever or infection. So that's another key part of the history, to say, is there anything that happened either at the time that these symptoms started or shortly before, in the days or weeks before, that you might be able to identify as an actual trigger, something that upset the immune system? Because if you can identify a potential trigger, that's actually better for the patient, because it's much more alarming is if this came totally out of nowhere, because it's more likely that that means it's a fundamental problem with the immune system that's going to keep coming and trying to attack the central nervous system. Versus if you can identify something like a preceding infection, or very rarely something like a vaccination that actually, caused the immune system to be overactive and it made a mistake, that's more likely to be monophasic and not go on and continue to cause a problem. Now, once you've identified an acute attack, something that sounds like a demyelinating syndrome, to actually make an MS diagnosis, you've got to prove two things. One, that the inflammation has happened in two different regions of the central nervous system, and that the inflammation has happened at least two different points in time. And the reason for that second part is because, as I mentioned, some people have one attack of demyelination, and it can be very typical optic neuritis, very typical transverse myelitis, and they may never go on to have another event. And those are not the people that you want to sign up for lifelong immune suppressing therapy. So the whole point of our diagnostic criteria is that it's trying to identify those people that are at risk for this inflammation to continue and keep causing ongoing damage. That's all MS is. And so that's why you need to have at least one defining event that sounds like a typical demyelinating event before you even interpret their MRIs. You got to have a high likelihood that what you're going to see on MRI actually matches or fits their clinical syndrome. So these are called our McDonald criteria for relapsing remitting MS, is the type of MS I'm talking about right now. This has undergone multiple revisions through the years, the most recently in 2017. And I'll leave this, for you to look back on in the future, as well as the reference for this paper, which is relatively easy to read. But where we use MRI is where if we can't get to the diagnosis just from a clinical history. So you can make a diagnosis of MS on clinical grounds alone. If they have 2 attacks and you've got proof on their exam that these attacks happen, some residual findings, that's enough to prove that they've had inflammation in 2 different areas and inflammation at 2 different times. So the case of the woman who had transverse myelitis and optic neuritis, from clinical history alone, with 2 attacks, you don't need any other information to make an MS diagnosis. However, in 2022, everybody gets an MRI for the caveat that this better not be explained by anything else. And so it helps us rule out other things and helps us confirm that what we see on MRI looks like demyelination as well. But often when people are coming in for their first attack, we have to use MRI to then show dissemination in space, which I'm depicting here. So from an MRI perspective, what you need to show is that you've got at least 1 lesion in 2 of these key areas. So lesions can be periventricular, juxtacortical, or cortical, in the infratentorial brain, meaning brainstem or cerebellum, or in the spinal cord. Now, you'll find that radiology reports often mention things that are periventricular. Rarely do they say juxtacortical or cortical. They might say more subcortical. And what I wanted to remind you of is that for the purposes of these diagnostic criteria, to make them more specific for MS, periventricular lesions, you gotta have one that is touching the ventricle, actually abutting the ventricle, such as here. Even though I'm sure that this patient who has MS, that this is an MS lesion, it's not actually touching. So we want, when we're making a diagnosis, to have at least a lesion that is touching the ventricle, if you're going to use that as one of the 2 main regions. Lesions can also be juxtacortical, but again, juxtacortical means actually touching or abutting the cortex, so buried here right out beside the cortex. They can also be within the cortex themselves, but most centers don't have this type of sequence, which is called double inversion recovery. So often you're more relying on a juxtacortical lesion rather than a cortical. Infratentorially, here's some in the pons, and here's one in the spinal cord of the patient that we previously mentioned. What you'll notice is that these all look morphologically very similar. So they're all round, ovoid, they're relatively well defined, and they're about 0.5 centimeter to 1 centimeter or so. So no matter where they are, they look relatively the same. And so all you need to show dissemination in space on MRI is just 1 lesion in 2 of these key areas. But how do you think you might show dissemination in time on MRI? How can we show on MRI that these spots have shown up at more than 1 time point? Well, the first thing that you could do is you could just do another MRI in the future. And if you saw any new spots show up, you know that that process is ongoing and that all the spots didn't show up at the same time because a new one has formed in the interval. And there's no set interval that you need to wait to try to prove that. The other thing you can do is if you have a mix of what are called enhancing lesions and non-enhancing lesions, is another way to show dissemination in time. So as we mentioned, in MS, when people are having these acute relapses, there's a breakdown of the barrier between the blood and the brain. Those immune cells traffic in, and they cause those aggregates of immune cells that cause inflammation. And so that same blood-brain barrier breakdown is where that gadolinium contrast leaks into, and lesions, those areas enhance with gadolinium. But that blood-brain barrier closes up and that gadolinium goes away after about a month or so. And so if you've got a mix of lesions that are gadolinium enhancing, but then you've got some that aren't gadolinium enhancing, you know they must have occurred at 2 different time points. And so that's another way on a single MRI scan, if you've got a mix of enhancing and non-enhancing lesions, that also satisfies our dissemination and time criteria because you know they showed up at 2 different times. Now, there are some situations where the patient has a typical clinical syndrome like transverse myelitis. You go to their MRI and they've got a spot in their spinal cord and they've got a whole bunch of regions of their brain involved, but the MRI wasn't done with contrast. So you can't quite get to that. Dissemination in time, but you think this patient's got to have MS, and I don't want to wait to do another MRI, 3 months from now to see if a new spot shows up, because the earlier we make the diagnosis and put people on treatment, that confers better long-term outcomes. So what our most recent diagnostic criteria have allowed for is using spinal fluid and the presence of what are called oligoclonal bands as a substitute for dissemination in time. And that substitute for dissemination in time is oligoclonal bands just mean that we see these bands of protein in the CSF that we don't see in the serum. So key parts of our diagnostic workup: good history and exam, trying to find that right time course, using your exam to try to find objective evidence that what they're telling us actually happened, using MRIs to then try to show dissemination in time and space if we can't get to the diagnosis just clinically. And I would tell you, always do an MRI at the cervical and thoracic spine, even if they don't have any symptoms attributable to it, because that region is implicated to help make the diagnosis. And the more spinal cord lesions that people have, the more prognostically unfavorable their disease is. And we're more likely to start higher efficacy medications early on for people that have a lot more spinal cord disease. Other key things of the workup include doing basic blood work, really looking for other reasons for white spots on MRI, things like vitamin deficiencies. Obviously, we're going to check vitamin D because we know it's a risk factor, but other things that can cause white spots like vascular risk factors. These two are other demyelinating conditions, MOG and aquaporin 4, that can also cause optic neuritis or transverse myelitis. If people have a history of some rheumatologic symptoms, you might want to do a screen for that, things like lupus, Sjogren's disease. If they have risky behaviors, you might want to check for syphilis and HIV. I would only ever check Lyme if they have a known history of a tick bite with a known rash, with neurologic symptoms that developed in the weeks or months following that tick bite. Otherwise, do not send it. And there are some drug-specific tests when you're anticipating starting treatment that are listed here. If you're looking for other evidence of demyelination elsewhere, we can look at things like visual evoked potentials or OCT to look at the integrity of the optic nerve. There are also some things that we expect to see on lumbar puncture that also come with positive oligoclonal bands. So taking these points into consideration, think about this case and whether you think they meet diagnostic criteria. So now this is a 53-year-old man, so a little bit out of our window in terms of when we might expect first onset of symptoms. He's got a 4-year history of intermittent dizziness and progressive imbalance. So the intermittent nature of it doesn't really fit with our typical syndrome. And progressive imbalance over 4 years also seems like too long of a time course for our typical MS attack. But in that time, he's noticed that he's losing some sensation in his feet that are rising up in his feet. He's very fatigued. common MS symptom. Maybe not as cognitively sharp as he used to be. Cognitive symptoms are really common in MS as well. He's got some vascular risk factors. And when you examine him, he doesn't actually have any objective central nervous system signs. Rather, his reflexes are actually reduced. He does have some reduced sensation in up to his ankles, which could be central or peripheral. Same as he's got some reduced vibration sense in his feet. He has some difficulty walking because of that loss of sensation. But if you work your way through these questions, do his symptoms sound classic? Well, no, they don't really sound like that time course that we'd expect. There are some signs on his exam that are attributable to his symptoms, but they're not central nervous system signs. They're peripheral nervous system, and MS is a central nervous system pathology. So even before we see this patient, no matter what we see on MRI, he can't actually get an MS diagnosis because he doesn't have a typical clinical syndrome. So your pre-test probability is low. But wait, he's got some periventricular hyperintensities. He's got some of these lesions elsewhere. And look, he also has some lesions in the pons, in the infratentorial brain. But this isn't multiple sclerosis. This is chronic small vessel disease. And so even though MS even though other diseases can give you white spots, in some of these areas, you need to have that typical clinical syndrome to help increase the likelihood that what you're going to see is due to MS. And chronic small vessel disease can give you what's called ventricular capping, but it looks very different than the round ovoid lesions in MS. Same thing here in the pons. Here's an MS-looking lesion here and here. This is more of a patchy, ill-defined hyperintensity. And so, this goes to show that you've got to have the right clinical syndrome that fits before you interpret the MRI. And in this person's case, they have a better explanation for their symptoms. It's likely their diabetes that has injured their peripheral nerve. They've got a peripheral neuropathy that has slowly damaged those nerves over the last 4 years. And so I want to just talk briefly about, the reasons for misdiagnosis. So misdiagnosis is as high as 10%, and the most common reason is an over-reliance on MRI in the context of non-specific symptoms and non-specific T2 hyperintensities. And I can't overemphasize how important it is to interpret the MRI only if your pretest probability is high. That is to say that their presenting symptoms are typical of an MS syndrome, which we've already discussed. And that really gets at, the reasons why a misdiagnosis is the symptoms are atypical, they don't have objective signs of central nervous system problems, inappropriate application of the criteria, and not recognizing MS mimics or MS red flags. And this has significant consequences, both for the patient and the healthcare system. One, if you make an MS diagnosis and put people on MS therapy, you're exposing them to unnecessarily risks of immune therapy. There's one study that showed that some people who had misdiagnosed, were on MS therapies for 10 to 20 years that they didn't need to be on. Also, if the diagnosis is incorrect, what aren't you treating for? If this was due to stroke and you're not managing their vascular risk factors, then that puts patient at undue risk as well. There's also a really strong support community for people with multiple sclerosis, and they often make their disease a real part of their self-identity. And so reversing an MS diagnosis is one of the hardest things that I have to do in clinic because they've made this a part of their life. There's also significant economic impacts, both to the patient, even just from a population level. The cost in the United States is upwards of $500 million a year for DMTs alone. It also confounds research if we're including the wrong people in our clinical trial. And I'll leave these kind of red flags for you to look at on your own time, only to say that there are clinical MRI spinal fluid red flags that you can utilize to help determine if this is MS or not. There's a nice mnemonic here called mimics that can also help you determine this. In the last few minutes, I just want to mention what happens with diagnostic delays and misdiagnosis. The longer the delay in referral to seeing an MS specialist, the greater the initial disability level at the time of their first visit. And all of our MS drugs, what they're designed to do is to stop new inflammation and stop new damage. They don't reverse the disability that's already there. And so we need to get to these people quickly and get them on treatment. And this has profound effects on patients' quality of life. The EDSS score is a disability score that we use to quantify our neurologic exam in people that have MS. You know, an EDSS of 4 is a relatively lower score. You know, unless you examine the patient, you probably wouldn't notice anything. But even at that relatively low score, if you ask a patient to express, you know, where they are in terms of their health status, they report a really rapid fall in their health status, even at a relatively low disability score. Same thing goes when you ask them where they compare to other people in the general population. So if you ask MS patients between the age of 18 and 29 how they'd relate their health status, it's the same as how much an 80-year-old would relate their health status in the general population. This also has significant effects on employment. And so people, the proportion of people with MS who are employed is greatly reduced, even at really low disability levels, and rapidly decreases as their disability increases. So this, again, has significant implications to young people who are going off work because of this diagnosis, and even of things like affordability of their own care, caregiver burden, etc. So it's really important that we get to these, we recognize these early symptoms, get them diagnosed, and get them on treatment. And I think that is where an MS center and rapid referral can really help in reducing that delay to diagnosis and getting people on therapy. And this is a plug for our group here at Stanford. So how do we optimize MS diagnosis? We want to minimize delays with rapid referrals. We want to screen for some of these red flags. And then we want to ask these 4 questions to get to the MS diagnosis. And so take-home points today, the diagnosis requires a typical MS syndrome that is consistent with demyelination. We want to be aware of red flags. We need to prove that there's inflammation in 2 different regions of the nervous system and at 2 different time points. If we can't get to it clinically, then we do it radiographically. And I want you to know that misdiagnosis and diagnosis delays do have significant consequences on the patient. And with that, that concludes our second lecture on MS. I hope you'll join us next time where we'll be exploring the different MS phenotypes, the concept of neurologic reserve, and its implications on early intervention and long-term prognosis. Thanks for your attention today.